I just want to do just a brief word of introduction for Ernest before he goes. I've known Ernest, I think, over 10 years at this point, and my first introduction to him, and I think you'll soon realize this as well, so I walked into a meeting as a very young lobbyist for a gay group down in Washington, D.C., and saw Ernest sitting across the table, and I was like, who is that guy? He is so smart, so strategic, and knew exactly what he was talking about. And to this day, exactly, nothing has changed. Ernest Hopkins.
Yeah, you know that you've been around a long time when you remember the dean long before she was a dean, and Chris when he was a junior at a staffer at a Human Rights Campaign. You know that you have been around. Thank you all so much for the invitation. It's great to see the crowd. It's really great to know that a place like this exists, first of all, and is in such great hands. I love Marla Gold. I just think she's amazing. She's always been an inspiration to me, and so much wisdom in the work that we did together with the Communities Advocating Emergency AIDS Care Coalition. Is actually how I first got to know her. So I've been asked to talk a bit about how people with HIV fare in healthcare reform. So let me frame it this way. I could frame it what we got, what we didn't get, and maybe I'll do a little of that, but let me just say that because of the nature of HIV, you could really say in some ways that the HIV community sort of began its healthcare reform with the beginning of federal resources being driven to the epidemic itself. Because the reason that those discretionary resources were allocated is because the public health system writ large was really unable and unwilling to respond to the epidemic in an appropriate way. It was unwilling and unable to integrate in any kind of effective way the kind of health care that should have been readily available across the board. And so back in 1990, we began our health care reform by creating the Ryan White Care Act, which is, if you will, a parallel set of systems and services that provide relatively universal access to people living with HIV for their medical care and their drug access and their supportive services that enable them to stay in care and to be able to adhere to their drug regimens. That being said, and with that history at our back, we were very careful in this process to understand that whatever was coming down the pike was going to be iterative, so it wasn't going to just be functional as soon as the pen was off the paper, and that we had better be sure that whatever we have in place, we kept in place until we were ensured that whatever was coming and was going to be implemented was going to, at a minimum, ensure that people with HIV were able to maintain what they had. And so the confluence of events, the guarantees and promises of healthcare reform coming actually coincided with the reauthorization of the Ryan White Care Act. And you know, the AIDS community has a long history with sort of infighting and a lot of aggressive posturing that's based on regionality and lots of other things. This time I have to say people were very smart and kept a lot of that at bay because they understood what was at risk. They understood that this was our safety net and it was important to fix certain things that actually were not working in the field, but not to make any effort to do any kind of wholesale review of the whole process that exposed the process to a lot of scrutiny from people who were looking for every dollar and looking for every ability to justify taking resources from the discretionary side that were going to have to be driven into what was going to be in any permutation a very expensive piece of legislation over time. And so we very cautiously and strategically moved the reauthorization of Ryan White through the process with the understanding that we were completely open to integration at a time certain in the future that we were going to be completely open to having people with HIV integrated in all the different components of the system. And so that's the way that we actually worked our process, and it was relatively effective. We knew, for example, during the stimulus package process, that there was still tremendous stigma around HIV. You will recall, if you don't recall it being HIV specific, you will recall that during the stimulus package, there was a huge firestorm around the fact that $400 million was included in the stimulus for quote unquote condom distribution. Well, it wasn't just for condom distribution. It was money for prevention and wellness support at the CDC that covered a whole array of services. But that was the buzzword, and with just that one buzzword, it struck $400 million that could have been in your community and other communities across the country providing health and wellness support to people living with HIV. And that was a very instructive message, not only to us, but also to people in the administration who were very clearly a little worried about where we were going to go with healthcare reform. And so the four things that are there for us, access, much broader access to people with HIV through Ryan White, through the community health centers, affordability, the ability to not only have your premiums paid through have your premiums supported through a subsidy, but also to have the rate of insurance increases decrease over time, and the ability of people with HIV who are at 133% of poverty, regardless of their AIDS diagnosis, to be included in Medicaid. Those are really important, big, huge things, which over time are going to actually shift the way that we're able to use the discretionary resources. Now, what we didn't get, obviously, is the undocumented are still out there hanging very precariously on a limb. They're currently still covered by Ryan White, but we're moving into a immigration reform environment. What's that going to be about? We still don't have enough primary care docs in the system to take care of all the people who we're now pushing into health insurance, and the care for people with HIV is complex. And so unlike a lot of the other healthcare reform conversations, we're not just focused on primary care, we also have to be focused on the specialty care side and how that specialty care is more integrated into the care that people receive across the board. And reimbursement. We run the risk of pushing a significant number of people into guaranteed access with no access to a physician because the physicians are not prepared to receive the reimbursement rates that are currently on the table and are beginning increasingly to refuse access, not just to people with HIV, but to people of low income across the board. And so, as Rebecca said, it was great that we fought, it was great that the bill is signed, and now all the work begins to make sure that all of these committees and all of these processes inside the government and on the Hill that actually will guide the implementation of this program are in place, and that we are at the table. We can't breathe. We cannot exhale. We have to make sure that we know what each of them are, and that we have assigned someone with a very specific task on each of them to ensure that people with HIV's needs are covered across the board. That's the next step. And between now and 2014, that's what we'll all be doing.